We're going to talk about hypertensive emergencies. This is something that many people have asked me about recently, and something that I think is important that we really get a good handle on of how to treat hypertensive patients in the pre-hospital arena. And we have a hypertensive emergency protocol that everyone's familiar with, but I think what we need to understand from a pre-hospital standpoint is there is a difference between hypertension and a hypertensive emergency. Many people that you come into contact with, many people that come into the emergency department are going to be hypertensive with a blood pressure 190 over 110, 120 that are going to be asymptomatic. If those patients are asymptomatic with that blood pressure, you really don't do anything for that patient acutely. Yes, those patients need to have their blood pressure lowered, but those patients need to have that blood pressure lowered over 24 to 48, 72 hours rather than acutely. Sometimes you can do more harm reducing blood pressures acutely in the field or in the emergency department. And you know, the benefit of reducing that blood pressure acutely sometimes can be very low, and it can actually cause problems. Depending on the literature that you read, hypertensive emergencies are blood pressures greater than 180 on the systolic side, greater than 120 on the diastolic side, with what we call target organ or end organ damage. Many people walk into the emergency department, as I said, with blood pressures 180 over 110, but they're not having any problems. Now, some people will even go out as far as systolic blood pressure of 220 and diastolic blood pressure of 120. If they're asymptomatic, they don't treat that acutely. But just keep in mind, somewhere between that 180 systolic up to 220 systolic, 110 diastolic up to that 120, 130 range. Once it gets above that, probably ought to start treating that in the emergency department, but I still probably would not treat an asymptomatic hypertension in the field. Yes, they may need to be treated, but that's something that we really don't have to do in the field. Now, changing the game a little bit if the patient has end organ or target organ damage. And what I mean by that, I mean chest pain, blurred vision, tremendous headache, congestive heart failure, pulmonary edema, focal neurologic deficits. Those people need to have their blood pressure lowered, and that is the definition of a hypertensive emergency. Do we have to treat those in the field? We still don't have to necessarily do a lot in the field. Those people probably need to go to the emergency department and they need to have their blood pressure lowered. As a general rule, we try to lower that blood pressure, and we try to reduce their mean arterial pressure by 25 to 30% over an hour. So again, most people are not going to have an hour transport. Yes, I understand that some people will, but many times we're going to have them at a hospital within an hour. So you can start the treatment in the field, but just remember that we're not trying to reduce that blood pressure very quickly. Now, the exception to that is an aortic dissection. If you know that a patient has an aortic dissection, and and I understand from the field that you may not know, but if you have a high index of suspicion, they have a tearing chest, lower back pain, they've had a syncopal episode, they don't have pulses in their feet, and you have a high index of suspicion, especially if the person tells you, well, I had an aneurysm in my chest, I've had an aortic aneurysm, they've been watching it, etc., then those patients do need their blood pressures reduced, and they need it reduced very quickly, over 5 to 10 minutes. That's going to be the thing that increases their chance of survival tremendously. So again, recapping, hypertensive emergencies are something that need to be treated. Reduce the mean arterial blood pressure by 30% over an hour. And I guess the thing that I guess people seem to get confused about is that hypertensive versus hypertensive emergency patient. The thing that I think people sometimes also get confused about is, what medication do I use? when I think you have to tailor that to the patient. I think labetalol or nicardipine is probably a better drug than the nitrates, but many services only have nitrates. They don't carry labetalol and they don't carry nicardipine. Labetalol is relatively cheap, but many services just don't carry labetalol. Nicardipine, on the other hand, is probably better than labetalol. I like nicardipine in the emergency department, but it's extremely expensive. Esmolol is another medication. It's a beta blocker that we use a lot in the emergency department to reduce blood pressures, especially on aortic dissection. Not only does the beta blockers reduce the blood pressure on an aortic dissection, but it reduces what we call shearing forces. Basically, it's just the intima of the aorta is just being sheared from that high blood pressure, and it reduces the shearing forces. So that leaves us many times in the field with nitrates, nitroglycerin. And does that have a place in pre-hospital blood pressure control? Absolutely. Now, I do think, depending on some of the literature that you read, many people will say that nitrates for headache, for blurred vision, for neurologic deficit is probably not a great medication for that, because it will cause a reflex tachycardia, and because of cardiac output, it can certainly cause a reflex blood pressure increase sometimes. But I think with congestive heart failure and acute cardiac syndromes with hypertension, I think nitrates are great. If you remember the Frank Starling mechanism, nitrates will reduce a preload. It doesn't. Lots of people think nitrates reduce afterload. It's actually a preload reducer more so than an afterload reducer. So if you think about the Frank Starling mechanism, you're actually reducing the amount of blood coming to the left ventricle, which will decrease your blood flow and blood pressure. So I think that nitrates certainly have a place for congestive heart failure and pulmonary edema in acute cardiac syndrome. Now, the run-of-the-mill hypertensive emergency with blurred vision, focal neurologic problems, then I think probably nicardipine and labetalol is probably a better medicine for that. Again, many services don't carry that. So I think you can tailor the medications that you have to each specific patient presentation, and this may be a time that you really need to get the physician on the phone and talk it through and see exactly what is better for the patient. And going back a little bit, some people have asked me, well, why don't we want to lower the blood pressure in the field, even though it's 220 over 140? Why don't we want to do that? Even if they're asymptomatic, it needs to be treated. It absolutely needs to be treated. But we don't want to reduce that pressure acutely in the field. These people have what we call auto-regulation. They're used to basically a set blood pressure that's higher than a normal blood pressure. So their brain and their heart and their kidneys are being perfused by that higher blood pressure. And if you reduce that blood pressure very quickly, you can actually decrease the blood flow to the heart, to the brain, to the kidneys, or the vital organs. And actually, as a result of that, you can precipitate a myocardial infarction or a stroke and long-term renal insufficiency. So that's the reason that we don't want to lower this blood pressure very quickly on asymptomatic patients. Yes, it needs to be lowered. It needs to be lowered quickly over 24 to 48, 72 hours. So I guess the recap is tailored. The treatment is tailored to the individual patient. One medication is not superior over another one for the global treatment, but for each individual patient presentation, you just have to think, get med control on the phone and talk with them about what's best to reduce that blood pressure.